Thanks, Jacob sir, for inviting me for this. So basically, I am not an intensive care physician. I am an infectious disease physician. So I'll be dealing with the topic infective endocarditis. So basically, from your level, what is to be known will be to see how do you diagnose, what are the investigation that you need to send, what are the treatment, and some other updates. Okay, so straight away. So most of the time we will be going with the ESC 2023 guidelines on infective endocarditis. So what they emphasize nowadays is that you can see there should be, for managing any kind of endocarditis, there should be something called as an endocarditis team, which involves cardiologist, infectious disease physician, microbiologist, intensivist, primary care physician, etc. So this is just about the team, and first you need to know when do you suspect an endocarditis. So whenever to suspect any case with a fever of unknown origin in the ICU, in a patient who has any prior history of cardiac illness, whenever there is any prosthetic valve patient coming with fever, when somebody themselves tell that we have a prior history of endocarditis, when there is a recent dental extraction and fever following that, and there is something called as infective endocarditis compatible organism. When you see this organism anytime in blood culture, you should retrospectively go and get an echocardiography done. So this is when you suspect an endocarditis. And when do these patients land up in an ICU? The usual reasons will be complication. So the common complication, the commonest complication that brings them to ICU will be if the patient goes into a septic shock, if there is any cerebral embolism, if there is cardiac failure. So the top three are the most common reasons. So around 40% of the endocarditis patient lands up in ICU with septic shock. 20 to 30% will be cerebral embolism, some of them with heart failure, and some of them for the need of a cardiac surgery or maybe after a cardiac surgery. Rarely extra cardiac involvement like respiratory failure, when they have complex comorbidities, acute kidney injury, all these are some reasons for endocarditis coming to the ICU. So about their epidemiology, so over the year there has been some change. Previously, nowadays mortality has reduced. Previously the mortality was 28% in ICU of endocarditis. Now it has come down to 23%. It is even as less as 8% in some studies, and more of valve surgeries do happen. Previously the cardiac surgeons were a bit reluctant. They used to tell that you can manage the endocarditis medically, but now things have changed. Now 40% of them go for surgeries. And age, old age, organ failure, stroke, that is complication, and if the organism is staphylococcus, these are some cases where the mortality is high. And whenever the surgery has been undergone, if there are some intracardiac devices, male gender, and if streptococcus is the culprit organism, these are some reasons where the survival is better. So classifying infective endocarditis, basically you can classify them into native valve and prosthetic valve. So among the native valve, it can be either community acquired, it can be hospital acquired or healthcare associated, or it can be in intravenous drug uses. Whereas prosthetic valve, we don't go in for such classification. It is either early or late. Anything less than 60 days is early. More than 60 days, we call it as late endocarditis. The difference is in whatever organism causes that also. So after 60 days, it will be, they will more go into the general population kind of thing. So any risk for the native valve will be applicable to whoever has prosthetic valve also. So how does endocarditis patients get the infection? So 40% of the time it gets in via the skin as a infection portal. So it can be either through intravenous abscess, if there is some surgeries that has happened recently, or if intravenous drugs are being used. So these are some reasons for entry of infection. And a lot of time we need to ask for a history of a recent dental procedure. 30% of them, after some dental procedure like teeth extraction, they do get infective endocarditis. I will come to that when we discuss the organisms. So next will be a gastrointestinal source. So some organism like say Streptococcus bovis, you are getting this organism in the blood culture, there is a possibility of infective endocarditis. Along with that, there is a high chance that there might be a colonic malignancy, a malignancy of the colon. So you need to know the names of some organisms and the associated sources. And so whether it is a streptococci, most of the time all the other streptococci mostly they come from the oral cavity. If it is staphylococcus, it comes from intravenous drug use most of the time. And others are like genitourinary, ENT sources. So these are rarer sources of endocarditis. Okay. So all said and done. So this is maybe the most important slide that you need to know. So infective endocarditis, compatible organism. So the story is not like the usual organism that you see in the intensive care unit, because gram negative organisms are much lesser causing endocarditis. Mostly it is gram positive, and the commonest will be staphylococcus followed by streptococcus. So the first will be staphylococcus, then streptococcus. So the only gram negative thing that can come will be this set, that is HASEC. So the expansion I am not going in, Haemophilus, Aphrophilus, Acno, Mycetocommons, Kingella, etc. So Staph lugdonesis and some newer organisms like Granulicatella, Abeotrophia. So all these are, except for the third one which I have mentioned over there. Other than this, all are gram positive. And mind you, this organism like pneumococcus, that is Streptococcus pneumonia and Streptococcus pyogenes, these are two organisms that are very unlikely to cause infective endocarditis. So all the other streptococci, whenever you see in blood culture, whether it is Streptococcus agalacti, Streptococcus mitis, all these Streptococcus aeruginosus, all these species, if accidentally it comes up in a blood culture also, retrospectively you always ask the cardiologist to get a detailed echocardiography done. In the setting of prosthetic valve, one of the commonest organism will be coagulase negative staphylococci. So the story differs in native valve. So in any blood culture, if you see these cones which we abbreviate, or coagulase negative staphylococci, in a routine blood culture, if this is seen, mostly it is a skin contaminant. Okay. But in the setting of prosthetic valve, if you get it, there is a very high likelihood that it is a case of prosthetic valve endocarditis. So always remember this organism. If you see in a routine blood culture, most likely it is a problem with your sample collection. But in prosthetic valve, the story differs. Same goes with these things also. These are some skin organism like Corynebacterium striatum and Corynebacterium jaecum. So many times what the microbiology lab does is that if they get this organism in the culture, they will tell that, okay, this is a contaminant, we are not reporting. But occasionally if this report comes and the patient has a prosthetic valve inside them, then you had it, because this might be the culprit organism. Treatment is easier, maybe with vancomycin you can treat all this stuff, but you need to know that this is not a contaminant in a prosthetic valve setting. Some other organisms, Serratia, Pseudomonas, Cutibacterium, all these are some organisms that can cause infection in prosthetic valve, and there is this kind of non-TB mycobacteria also that can cause infection. So suppose you are getting a culture negative endocarditis, you can go in trying for this organism, and of course fungus like Candida also can cause endocarditis. Okay. So going to the next. So how should you send a blood culture if you are suspecting endocarditis? So in the recent 2023 they have made an update to what we all have studied in MBBS days, that is the Duke's criteria. So now things have changed. So now what they say is 2 positive culture of this typical organism. Typical organism is what I have mentioned in the previous slide, Streptococcus, Staphylococcus, and maybe Enterococcus also. So more than 2 positive culture of this typical organism. So previously what has been said is that for an infective endocarditis diagnosis, you have to keep sending blood culture, 3 cultures within 1 hour in a gap of 30 minutes at least. So now those things are not there. The time interval between samples have been removed. So suspecting endocarditis, you can send all the cultures at the same time, provided you are taking the blood from different areas. So you can take one from the right side, one from the left side, and maybe one from the central line, and you can send like that. But so for a diagnosis, just 2 culture of typical organism is sufficient, and 3 cultures. Suppose you are getting Pseudomonas, so maybe that is not a typical organism. So in those cases, If 3 cultures are positive, then it is highly likely to be infective endocarditis. So, blood cultures are to be collected from separate sites and time interval has been removed. Now, things have advanced. Suppose your cultures are negative, then also you have ways to diagnose endocarditis. So, for that we have this non-culture diagnostics. So, this first one which I have written, Coxiella burnetii, that is not usually common in India. So, you can leave that aside. What you can send in your ICUs, or if it is asked for an exam, what you can mention is these things: PCR and sequencing, metagenomic sequencing. So, PCR 16S RNA is for bacteria, 18S you see for fungus, and metagenomic shotgun sequencing. So, you just take some blood and send it for sequencing. If some bacteria is there, because blood is supposed to be a sterile media, okay. If your echo is showing a vegetation, your normal blood culture has not grown anything, you can just send the blood for sequencing. So, now there are so many people that are providing sequencing like MedGenome, Haystack, so many people are providing. So, you just send it for sequencing. If some organisms comes back and if it is a compatible one for endocarditis, then you can keep your diagnosis, okay, this organism has caused the endocarditis, okay. And next one I am not dealing with. So, now what imaging do you send the patient for? So, always, as you know, the first test that you need to do is a transthoracic echocardiography. But the problem is that in a native, what I have written here is, in a native valve endocarditis, it is only 60 to 70% sensitive, and the specificity sensitivity in a prosthetic valve is only 50%. Okay. So, suppose you got a streptococcus or staphylococcus in blood culture, and you are thinking that, okay, there is a probability of infective endocarditis, you have a suspicion, always you should recommend for a transesophageal echo, which is an excellent sensitivity in native valve as well as prosthetic valve endocarditis, and 90 to 100% is the sensitivity. Okay. Specificity also is quite good. So, if you tell that it is not there in a transesophageal echo, most of the time it is not an endocarditis. Okay. Now, when the new guidelines came, they have emphasized some other imaging investigation also. Example, this cardiac CT. So, this is getting prominence. It is said that it is equally good, and it is even better for diagnosing things like paravalvular abscess and pseudoaneurysm. Okay. To see whether the vegetation is there, the best test will be a transesophageal echo, whereas to see if there are complications like a paravalvular abscess, you can go in for cardiac CT. Other investigations are always PET CT is a very good investigation, especially if there is a prosthesis. Okay. But for sending, or even in native valve endocarditis also, that is good. Suppose a patient is going in for a PET scan from your ICU. Okay. So, suppose the PET scan is scheduled for day after tomorrow. Is there anything that you should do for the patient? So, for this, because the normal cardiac tissue has a very high activity. So, what we can do is, you can suppress the cardiac activity, and most of the time the simplest way to do it is to give the patient at least 24 hours keto diet. Okay. You can ask a dietitian to provide a keto diet for the next 24 hours. So, the normal cardiac activity will be suppressed, and if there is a vegetation in the valve, that will light up. Otherwise, this cardiac activity might mask the endocarditis thing. So, always 24 hour, at least 24 hour, maximum of 72 hour of keto diet will be something that could ideally pick it up in a PET scan. And even SPECT scan also has been recommended in the newer guidelines. So, what is new is the cardiac CT, role of cardiac CT. Now, this is another change in the due criteria. So, previously this thing was not there. This came up in 2023. Suppose a surgeon is doing a surgery. He has opened up the heart and he has seen a vegetation. So, that is a definite criteria that there is an infective endocarditis. Okay. There is nothing much to discuss about. Somebody has visually seen a vegetation. You accept that this is endocarditis. Okay. So, this is the 2023 due criteria. So, there are major and minor criteria. So, among the major criteria, what I have highlighted is the things that have been updated. So, now they have told there is no 3 culture, 2 cultures are sufficient. You can take it from the same at the same time, and some new things. All these are very fine. Nothing, you need not read this. But what you should mention is that echocardiography and cardiac CT is very important. PET scan has a significant role nowadays, and if there is an open surgery, a vegetation has been seen, you take it for granted that there is endocarditis. Okay. So there is some minor criteria also. So minor criteria, this is like from all your MD entrance classes, you have studied all these minor criteria. There is not much change in these things. Glomerulonephritis, Osler's node, Roth spot for immunological and vascular phenomena, emboli, Janeway lesion, splinter hemorrhages, all these things can diagnose endocarditis. Okay. So what has been told is if two major criteria are satisfied, that is endocarditis. 1 major and 3 minor, again it is endocarditis, and 5 minor criteria alone, still you can say that it may be endocarditis. So what has come in the latest criteria is if everything is negative in this, what you call is the criteria is rejected for endocarditis. So that part has come in the new guideline. So now coming to how do you treat infective endocarditis, I will come to whatever guidelines. Before that, for practical purposes, you need to know some points that you should apply before treating any endocarditis. So some of these are the dictums. One is there is an age-old concept of bacteriostatic antibiotic and bactericidal antibiotic. It is not like that bacteriostatic won't kill the bacteria. That concept is wrong. So nowadays it is mostly a technical term with respect to the MIC and the minimum bactericidal concentration. So there are, if you ask microbiologists, they will tell there is something called as an MIC, there is an MBC. So it is upon the ratio of this. If the ratio is less than 4, they tell that this is bactericidal. More than 4, they tell it as bacteriostatic. There is nothing like the bacteria is not killed in bacteriostatic. So you can use any antibiotic. So the take home point will be you can use either a bacteriostatic and bactericidal agent, and no trials have proven that bactericidal are much better in endocarditis. But practically, since some antibiotics have been proven good, we are still continuing using them. Okay, so combination therapy, in all cases you don't need a combination therapy. So for some fragile organism like Streptococcus, maybe only one antibiotic is sufficient. MRSA, one antibiotic might be sufficient. But there are some cases like say Enterococcus. For Enterococcus, you need to give a combination therapy. Okay, and there is something called as an inoculum effect. I am not explaining it much, but if there is a big load of bacteria, theoretically it is said that antibiotic like cefazolin might not work. But nowadays it is said that this is theoretical. Again, cefazolin works in these cases. And this is something new that has come from 2018 in infective endocarditis, that is a POET trial. POET trial is partial oral endocarditis therapy. So nowadays the dictum is whole therapy need not be given as IV. You can give 2 weeks of IV therapy, and following that you can finish the endocarditis treatment with oral drugs. There is a list of oral drugs that have been suggested like linezolid, there is clindamycin, there is cotrimoxazole, there is a big list. Okay. And prosthetic valve endocarditis, there is some difference, because in prosthetic valve patient getting admitted to your ICU, you start with a lot of time there is staphylococcus, so you give vancomycin, but one thing is there is a risk of biofilm, so there is a nidus of infection. So for those biofilms you can give this antibiotic rifampicin also. So rifampicin has a role in prosthetic valve endocarditis. There is not much of a role in giving it empirically in a native valve endocarditis. So for treatment, there is a set of guidelines. Okay, streptococcal endocarditis you have to give so and so. For staphylococcal you have to give so and so. So it is very difficult for you to by heart. Even we also don't by heart all these things. We also use things like say UpToDate or Medscape for seeing this. But you have to apply some dictums. So they are like streptococci, it will be either penicillin works or ceftriaxone works. Okay. And maybe you can apply for a synergy with gentamicin. So if gentamicin is given in a if along with penicillin or ceftriaxone, a lot of streptococci can be endocarditis uncomplicated can be treated with just 2 weeks of therapy. Okay. So if you are not giving gentamicin, it will be a 4-week therapy. So that is about streptococcus. Staphylococcus, So there are two types of Staphylococcus. One is methicillin sensitive and methicillin resistant. For methicillin sensitive, always the best drug is cefazolin. Cefazolin stands first. It is better than ceftriaxone. It is better than vancomycin. Okay. So that is about methicillin sensitive. MRSA, nowadays you have a lot of drugs. So you can either give vancomycin. If there is teicoplanin is good, provided the dose of teicoplanin will be 10 to 12 mg per kg. So maybe in a 60 kg person, the dose will be somewhere between 600 to 800, not the 400 mg that is being given for a lot of cases. Daptomycin is a really good drug. The dosing will be somewhere like 10 mg per kg, daptomycin. And daptomycin can be given as a combination with ceftaroline also. So daptomycin, ceftaroline, and even fosfomycin also can be given. So these combination you can apply. And if the blood culture is showing this organism named Enterococcus, there is a difference. So Enterococcus is something which are intrinsically resistant to cephalosporin. Okay. So in enterococcal endocarditis, either you give ampicillin, you can give ampicillin gentamicin. Just for synergy purpose, you can give ceftriaxone, but it will be resistant. It only the ampicillin will act properly, and ceftriaxone is just for synergy. Or you can give vancomycin. So enterococcus, either you give ampicillin or you give vancomycin. So that's how your answer should be. And so ampicillin gentamicin synergy, or you can give vancomycin or daptomycin. So enterococcus is almost always like MRSA, except the thing that in MRSA you give, in MSSA, Staphylococcus you give cephalosporin, but in enterococcus no cephalosporins work. So these are some dictums that you should apply before going in for treating endocarditis, and after that you can just go into whatever antibiotic can be given. So if it is a streptococcal endocarditis, so applying the principle that we have told, it will be either penicillin or ceftriaxone. You can apply a synergy with gentamicin. If it is an oral streptococci, penicillin, if it is a, the dictum remains same for native valve and prosthetic valve. Only thing is, native valve treatment will be 4 weeks, prosthetic valve the treatment will be 6 weeks if it is streptococci. Again, if there is an allergy to beta-lactam, maybe you can give vancomycin. Vancomycin will be the agent of choice in these cases. Okay. So there is not much of a difference between native and prosthetic. If you go for Staphylococcus, it can be MSSA or MRSA. MSSA, as I told, either cloxacillin or cefazolin. Many times the patient won't be comfortable with this thing called cloxacillin or flucloxacillin. Why? The dosing will be 6 times many times, 2 gram 6th hourly or 2 gram 4th hourly. Patient won't be happy. You give cefazolin 2 gram 8th hourly, it will be even convenient. Okay. And there are now the new older guideline used to say that the oral therapy like cotrimox or clindamycin also may be given, but newer guidelines are not saying this. If it is prosthetic valve, there is a difference. In Staphylococcus, you should add rifampicin. So this dictum should be followed always. Penicillin allergy also you can use cefazolin. Daptomycin is a really good drug. With daptomycin, you can give this cephalosporin called ceftaroline, because ceftaroline is one of the antibiotic cephalosporin that is active in MRSA. In methicillin resistant, it will work. In MRSA, ceftriaxone won't work, cefazolin won't work, but ceftaroline works. Fosfomycin also may be added. So nowadays it is said that in native valve endocarditis, there was this study called Camera 2 study. They said that there is no need for combination. Okay, it is not like, okay, I have got an endocarditis here, so I will try with whatever is there, vancomycin, daptomycin. That is not needed in these cases. So if it is prosthetic valve, you can add rifampicin or maybe gentamicin. So this daptomycin is a drug that is upcoming. So many times you have a lot of problem like renal failure in the ICU, where you might not be able to give vancomycin. So in those cases, MRSA endocarditis, your choice will be daptomycin, and for better efficacy, you can give these combination things like ceftaroline or fosfomycin. So this combination therapy will have some risk like Clostridium difficile, or there is, if you give fosfomycin as an antibiotic, most of you will know the patient will get hypernatremia. You can see even sodium values of 170, 180 like that. So, but nowadays what the consensus is, daptomycin combination therapy can be given in persistent bacteremia and if there is a therapy failure. Enterococcus endocarditis. Nowadays only Enterococcus faecalis is what is said to cause endocarditis. What you can use is either ampicillin with ceftriaxone or ampicillin with gentamicin and or vancomycin gentamicin. So Enterococcus, you should remember, it is always a combination therapy. It is the only, in fact, it is the only thing where always combination therapy is recommended. Either you give ampicillin with ceftriaxone, ampicillin with gentamicin or vancomycin gentamicin. Either way, it is always a combination. So many times as intensive physician, what happens is your culture report comes after 1 or 2 days only, after 2 or maybe 3 days. So in those cases, you will have to go for an empiric therapy. So if the patient is having a prosthetic valve, or if the patient is having, there you have a high suspicion of endocarditis, you should start with some empiric therapy. So what will be recommended will be either, if the patient is severe, you can give ceftriaxone along with vancomycin, which will cover almost everything, or you can give ceftriaxone with daptomycin, or ampicillin with ceftriaxone with gentamicin. If you are an antibiotic steward and you don't want to give vancomycin, maybe ampicillin, ceftriaxone and gentamicin, because native valve endocarditis, it is not caused by much of resistant organism except maybe MRSA. Okay, so ampicillin with gentamicin also, it will help most of the time. If it is a prosthetic valve, you can start with vancomycin, gentamicin and rifampicin, and very rarely you can try antibiotic like meropenem, but most of the time practically we don't need antibiotics like meropenem for treating endocarditis. You just get the organism, and almost always it will be like, it will be sensitive to ceftriaxone. Nowadays oral therapy, from an ICU point of view, I am not discussing the oral therapy much, because you just need to know that there are some antibiotic to which you can step down. So it can be amoxicillin, it can be linezolid, moxifloxacin is one antibiotic in streptococci. If it is staphylococci, you can give dicloxacillin, moxifloxacin or linezolid. And MR methicillin resistant, you can give linezolid. You have options. Okay. So you should know whom to send for a surgery in endocarditis. So there is emergency surgery as well as urgent surgery. So emergency surgery has to happen immediately within 24 hours. So if the patient is in a severe heart failure, and patient is in cardiogenic shock, and those people won't improve without surgery. So that is one indication for surgery. If there is an uncontrolled infection, it is going to be an urgent surgery. Urgent surgeries are those surgeries that has to happen within 7 days. And if the vegetation size is more than 10 millimeter, again it is an indication for urgent surgery. If there is valve abscess, if there is pseudoaneurysm, if the size of vegetation is increasing, all these cases you have to go for surgery. If it is an early prosthetic valve endocarditis also, it is better that the valve is changed. Okay, it is very difficult to preserve a valve in early prosthetic valve endocarditis, that is within 2 months, because it might be lost of time. It is a hospital acquired organism which might be a resistant Klebsiella or even an Acinetobacter pseudomonas. You will find it very difficult treating it without the surgical removal of the valve. Okay, but if it is a late endocarditis, prosthetic valve endocarditis, it is just like treating a native valve endocarditis. So those cases you can just give IV therapy and you can do away with. Okay, so this is a case scenario. 45-year-old male developed VAP, Klebsiella pneumonia, but now the blood culture is showing Candida tropicalis and echo is showing a vegetation. So Candida again has become a culprit organism for endocarditis. So fungal endocarditis, the story is different. So as a reflex, you would say that Candida, you give fluconazole. Okay, in endocarditis that is not the story. Fluconazole is much inferior. You never give fluconazole early, you give any other agent. So coming to the dictum, fungal endocarditis has this problem. It can cause biofilm. Antifungals won't penetrate into the vegetation, and vegetations are basically avascular structure. So it is very difficult if there is no good blood flow. So fungal endocarditis, almost always the dictum is surgery. So whatever data I am showing here, it is said that the surgery has a much higher benefit compared to those without surgery. So it is said that the survival rate is 64% if there is combined surgery with antifungal, whereas it is only 35% in only antifungal. So always recommend the CTVA surgeon for surgeries. So the treatment, the grade 1 recommendation itself is must be treated by urgent surgery. So if not, you go for antifungal. So the antifungal, it is always a combination antifungal. So the best choice will be amphotericin, liposomal amphotericin along with flucytosine, or you can give caspofungin. But the recommendation is that caspofungin dose is not 50 mg, it is 150 mg that is recommended. Or you can give micafungin of 150 mg or anidulafungin of 200 mg. Most of the time it is like a double dose or triple dose that is to be given in endocarditis. Okay. So now some recent guideline have said that okay, you can try giving 50 mg caspofungin also, but the evidence is quite sparse. So you can step it down to fluconazole only after the initial period of at least 4 to 6 weeks or at least 2 weeks of IV therapy. Then you can step down to fluconazole when the candida load is, patient is clinically stable and the blood cultures are negative. That is the time when you can start fluconazole. Other than that, even if the culture is showing fluconazole sensitivity, endocarditis, you start with the regime on this side. You have alternate step down options like voriconazole, posaconazole, etc. And candida endocarditis, always you send blood culture, keep sending blood culture every other day, every alternate day, and you need to see that the candidemia clears. Then only you can try for some oral therapy like fluconazole. So if it is a native valve fungal endocarditis, treatment duration is 6 weeks, and if the cardiac surgeon is not ready for a surgery, then many times there is a long-term suppression therapy with fluconazole will have to be given, especially if the prosthetic valve, if the surgeon is telling, okay, I am not doing a surgery for this patient again, maybe even some patient might end up getting the treatment lifelong. Okay. So always better to get valve replacement, and chronic suppressive therapy might be required in a lot of cases. For endocarditis follow-up, PET scan can be used. So PET scan can guide the therapeutic decision making, and it can decide whenever the treatment can be stopped. This is a next challenge, culture negative endocarditis. Suppose all the cultures are negative, then you can go in for option that I told at the beginning, that is something like sequencing. Okay, but many times the cultures are negative only because of this reason, because the patient has already received a lot of antibiotic before you send a proper culture. So that is one common reason. So if the patient is clinically improving, if there is a vegetation and there is no fever, there are two explanations. Either the patient is improving or it might be a fungal endocarditis. A lot of fungal endocarditis like aspergillus does not have fever. Okay. So if culture negative, you should think about these kind of rare organism like Coxiella, Bartonella, or it is not an infection. So in rheumatologic patient, there can be non-bacterial thrombotic endocarditis. So they are again ephemeral. So whenever possible, you can send for PCR or sequencing in such cases. This is something that is coming up. So non-tuberculous mycobacteria causing endocarditis. So these are some species. This is the most notorious species of endocarditis will be Mycobacterium chimera. So if the patient is culture negative, you should send for a AFB culture, acid fast bacilli culture, that will pick up this organism like Mycobacterium chimera, Mycobacterium abscess or Mycobacterium cheiloni. So many times during the bypass surgery, they use these heater cooler devices. So after a bypass surgery, if somebody is getting endocarditis, keep this thing in possibility, Mycobacterium chimera. Think about the neurology complications always, because this is something that lands up the patient mostly in your ICUs. So always in embolic brain CT or MR angiography can be done if you are suspecting a cerebral aneurysm, mycotic aneurysm. And in embolic stroke, mechanical thrombectomy can be considered. But if there is an endocarditis and there is a stroke, now what the ESC recommend is that thrombolysis is not recommended if you are sure that there is an endocarditis, because there is a very high chance of bleeding. There is intracranial hemorrhage is a neurology complication, and if there is a major bleeding, you should interrupt antiplatelet therapy. This is another topic, right-sided infective endocarditis. Most of the time, most of the cases that I was telling as of now was a left-sided endocarditis like mitral and aortic. Okay, this is a rarer thing. It is not very rare because a lot of IV drug abuses are out there. But the thing is that It is not as severe as a left-sided endocarditis. So it usually occurs in injection drug users and catheter-related infection and implantable electrode device. I am not going into those details. But if somebody is having an implantable electrode device, maybe something like a pacemaker, and patient is having endocarditis, the first thing to do is to remove the pacemaker. Now, even now with the medical science so much advanced, there are not much regimes to salvage the pacemaker and treat the patient. Okay, you will have to remove the device and the leads. Okay, and right side endocarditis are usually less severe. Okay, thank you. Any doubts? Any questions? Minimum 3 samples. 3 samples. Okay. You need to get 2 positive cultures. So you send 3 samples. Culture negative, and if you are having a high suspicion, always you should repeat it. Annarum 3 samples. Cultures, there is another thing, because in MRSA, say the organism is MRSA. MRSA has something called a skip phenomenon. Okay. It can remain dormant in some place. So you do a blood culture, many times the MRSA might not be there in some cultures, and in the next culture it might be there. This especially happens with following treatment. So the thing is, due to this skip phenomenon, if there is an endocarditis, you should keep sending multiple cultures in MRSA and Candida to document the negativity. Because if there is a vegetation, some organism only might have caused the vegetation, right? So that is when you should send. If the patient is persistently afebrile, patient is a rheumatologic patient, then this might be non-infective. But if vegetation is there in the heart, in the echo, it is always something has caused this thing. So you go in for your empiric therapy, like what I have shown, ceftriaxone, vancomycin. And the problem is that if you have not got the organism, you don't know what is happening. So you will end up giving ceftriaxone and vancomycin for the patient for 6 weeks. So that's what is going to happen. So always in endocarditis, try for your diagnosis. And if the patient is stable, relatively stable, it is not like you need to start an empiric therapy also. Okay, you can just wait till the culture comes and then you can start treatment. Even that is recommended in endocarditis, because not everyone is going in for a complication like intracranial in embolic manifestation or something. Okay, you can wait till you get the culture. If not getting, maybe it would be better, at least in the prosthetic valve endocarditis coming to your ICU, you can try sending for sequencing, because the cost effectiveness will be much better, because maybe sequencing will cost around 8,000 to 10,000 rupees, and if you get the organism, you are safer. Okay, if you are not getting an organism, you treat the patient for 6 weeks, again the patient coming back with a bigger vegetation, that's a bigger problem. Okay. NGS metagenomic shotgun, either sequencing വേണമെങ്കിലും വിടാം. Difference എന്ന് പറഞ്ഞാൽ NGS is like an expanded PCR. It is like a PCR. So there are a lot of organisms that they will see. Metagenomic sequencing, what happens is that it can even pick up what is not there in the target. Okay, it can tell that okay, there is some other sequence that, so it will go into a database, and from that database you will get the answer. But usually what these labs do, like MedGenome, Abstract, most of the time they will prefer NGS because it is cheaper. They have a set of organisms that will cause. It is definitely better than PCR in this case, but maybe if it is a very rare organism, you still have a chance that you are not getting it. Yeah, ceftriaxone is available. You give it at 600 mg TID. It is a very good drug for MRSA, and it is good. Ceftriaxone is good. Side effects are less, except that there are some neurologic side effects. Maybe occasionally patient can get neuropathy. Some of them can get seizures. So these kind of some issues do crop up.
Sodium and other metabolic disorders. Today we'll be dealing with low and high sodium as well as hypercalcemia. We're not covering the other things. So basically hyponatremia, it's associated with a mortality of about 30 to 40%, and the reason is because of cerebral edema and cerebral edema related issues like herniation and so on. So you've got severity, it can be mild, moderate and severe. Severe hyponatremia basically means sodium levels are less than 120. So how will they present? It's because of neurological symptoms. So there's a shift in the fluid from the extracellular compartment to the intracellular compartment because of the sodium being low on the outside and relatively higher on the inside of the neurons. So there will be cerebral edema, so it can range from mild symptoms like headache, nausea, vomiting, and serious issues like impaired consciousness as well as seizures. So in chronic hyponatremia, some cerebral osmoles are formed, so there's some cerebral adaptation, so they need not present with these kind of drastic neurological symptoms. Now, once you've identified the patient's got hyponatremia, you have to find out why did they get it. Have they had some electrolyte-rich fluid loss because of vomiting, diarrhea, or some diuretics that they've used? Have they just drank too much water because of polydipsia? Is it because of medications? See, medications like antidepressants, anti-epileptics, these antipsychotics, they act on the central nervous system. They can cause SIADH. So that can cause hyponatremia. Diuretics will cause loss of sodium. Previous records of sodium should also be looked into. If it is available, look at the previous records. Is it chronic or acute? Chronic means basically it's been there for more than 48 hours. So you don't have to aggressively treat it unless they are seriously symptomatic. Now look at the volume status. Ultimately, everything comes back to volume status when it comes to managing hyponatremia. How do we evaluate? There are a multitude of tests that you need to do, but most importantly, do the glucose, do the serum osmolality, urine osmolality, and the urine sodium. Then the TSH and cortisol. We all do this. The rest of the things are basically to exclude other causes of hyponatremia. Now, so this is basically one of the flow charts. What you will do is first look at the sugars. Sometimes patients might have really high sugars, 600, 700 in those kind of ranges. If that is the case, this will show falsely low sodium values. So there's an equation to figure out the correct sodium in the event of high sugar values. Assume that the patient's normal sugar value is 100. For every 100 milligram per deciliter above this, the sodium will be shown to be 2.4 less. So find out how many hundreds it's more than the normal 100 and then multiply it with 2.4, add it to whatever sodium you have and you will get the actual sodium. So there's an equation, use the equation. So when you get the actual sodium, it need not be hyponatremia in the beginning itself. So rule that issue out. Check the glucose first. Subsequently, check the plasma osmolality. So plasma osmolality can be measured, it can be calculated. We need the measured plasma osmolality, which is it's figured out by something called a freezing point depression method. So the lab will give you the measured osmolality. Check how much it is. In a patient who is truly hyponatremic, their plasma osmolality should be less than 280 milliosmol per kg. In other conditions, supposing they are hypertonic or isotonic, these patients are not truly hyponatremic. So supposing you're getting a serum osmolality more than 295, the reason this has happened is because there are some highly osmolar things in the extracellular space which is accounting for this hypertonicity, and it's falsely showing the sodium to be low. So these hyperosmolar things can be things like mannitol, glucose, glycine. Glycine happens because of TURP corrections and glycine containing fluids that could have been used. So if this is there, correct these problems, the sodium will settle. On the other hand, isotonic hyponatremia basically means the tonicity is normal, in the normal range, 280 to 295, but still the sodium is seen to be low. You don't have to correct this. This is also a very normal situation. Why it happens is because it's a lab issue, lab testing issue. It's a pseudo hyponatremia. You take the sample of blood, sample unfortunately contains high levels of lipids or paraproteins. So these will occupy more space and the sodium in that will be less. So it is invariably showing it as low sodium, but is actually not there. These osmoles are ineffective. This is not contributing to the osmolarity at all. They will move between the cells easily. They won't cause any symptoms. So if you are seeing a patient who has got hyponatremia, check the tonicity. Hypertonic and isotonic are not true hyponatremias. Hypotonic is the actual true hyponatremia. So come to the hypotonic. It is less than 200 milliosmol per kg. True hyponatremia, check the urine. Why we checking the urine is because some people just drink a lot of water. Primary polydipsia because of some psychological issues, or beer protomania, or somebody who's had a lot of tea and toast. They're just drinking a lot of free water which doesn't contain any solute. So this free water in the body is diluting everything out and showing the sodium to be low. In these patients, you just check the urine. The urine will also be very dilute. In these people, just manage their fluid intake. The sodium will set itself correct. You have to exclude all these things before we come to the actual sodium issues which are related to the volume status, because these have definitive management. So now look at the volume status. Check the volume status. Supposing the patient is hypervolemic, that is a high volume which is causing the sodium to be low. Why is the volume high? Because of some organ failure. That is, could be the kidney, could be the liver, could be the heart. In this, you check the urine free sodium. If it is a renal failure issue, the urine free sodium is also going to be high. The kidneys are not able to concentrate and it's just going to come down. So it will be more than 20. If it is less than 20, it's probably a cardiac or liver related issue. So manage those problems. That is hypervolemia on that end. Hypovolemia. Why is hypovolemia happening? There is a loss of fluid from the body. There is a loss of sodium also from the body. But the sodium loss is much more than the fluid loss. So the loss can happen in multiple places in the body. It can be lost in the kidney, it can be extra-renal as well. So if you're losing it extra-renal, probably it's diarrhea, vomiting, burns, pancreatitis and all that. If you're losing it in the kidney, it's some renal tubular acidosis or diuretics which you have given. So you've lost the fluid, you've lost the sodium, but the sodium loss is so much more than the fluid loss. That's why you're getting the hyponatremia. Now in some patients, volume status will be fine, but the sodium is low. Why? This is because of hormonal issues, endocrine issues. So that could be because of low thyroid hormones, adrenal insufficiency, ADH being too much. So you have to manage those conditions differently. So next is basically how will you manage? Initial management is manage the symptoms. If there are any pressing symptoms like headache, nausea, all of those things, or serious issues like seizures, manage the symptoms first. Subsequently, you manage individual conditions and those conditions which have caused all these problems. Keep in mind that chronic hyponatremia has greater risk of complications from excessive therapy. So acute hyponatremia causing symptoms you can aggressively correct, but chronic you have to be a little bit more cautious. How would you go about correcting all these things? So previously we mentioned the hypertonic and the isotonic. If you remember, hypertonic is because of, I already mentioned, those hyperosmolar agent, remove the agent. Isotonic I mentioned is because of ineffective osmoles. It's not going to do anything there. The patient is going to be asymptomatic, so you don't have to bother about it. The hyponatremia, the true hyponatremic patients who are hypotonic, in these patients, supposing they are symptomatic in an acute hyponatremia, you have to give hypertonic saline. So 3% hypertonic saline boluses can be given, and your target is to increase it by 6 millimole per liter every hour for about 6 hours. Not 1 millimole per liter every hour for the initial 6 hours. So target is only increase it by 6 for 6 hours. In a 24-hour period, not more than 12. So this is in a patient who has got acute hyponatremia, quickly corrected 6 over 6 hours, not more than 12 in 24 hours. If it is chronic, they are not going to be very symptomatic. You can just correct it with some normal saline. And again here also, don't correct excessively, not more than 10 to 12 in 24 hours. So you manage the initial problem, the symptoms. Now you have to come to the individual conditions and manage each of them. So the hypotonic hyponatremia is a true hyponatremia in that if there is a volume issue, you've lost volume somewhere, replace the volume. Extra-renal or renal loss of volume, replace the volume. If it is euvolemic, that is, you have already mentioned the SIADH, mineralocorticoid deficiency, hypothyroidism, give the hormone and manage that. If it is SIADH, there's too much ADH, block the ADH. Use Vaptans or demiclocycline and block it. Next is hypovolemia hypervolemia. That's because of cardiac, renal as well as liver failure kind of situations. Restrict the fluid, and you can give diuretics also if you want. So this is how you would go about managing it. So we already mentioned in severely symptomatic patients in the first 6 hours, try to increase it by 4 to 6 milliequivalents per liter. So if they're just coming to you in seizures, you can't sit and calculate all these things. Just give 100 ml boluses of 3% hypertonic saline, up to 2 extra boluses also you can give. So if the symptoms don't resolve by about 30 minutes, this is how you would do it. So next is how will you correct it? Like how much are you supposed to give? The sodium, the deficit you have to calculate first. How would you go about calculating this is, you have to see what's the desired change in sodium that you want. So in my patients as symptomatic, I want to increase it by 6 in 6 hours. The desired change in sodium that I want is 6. I have to calculate the total body water of the patient. That is based off the patient, the gender basically, and the age also. So if it is, for example, a 70 kg patient has come to me, symptomatic, the sodium is 105, I want to increase it by 6 in 6 hours. This is how much you should increase. Don't go beyond this. With this correction, it should improve. So how am I going to do it? I'm going to calculate the patient's total body water. So that's 60% of his total body weight will be his total body water. For a female, it will be 50%. So 0.6 into 70 will give me his total body water, and the desired correction that I want is 6. So multiply all these things, I will get 252 milliequivalents per liter. This much sodium I have to give for the blood, for it to reflect in the blood to increase by 6. How am I going to achieve giving this much? So you have to know how much sodium is contained in each fluid. 3% hypertonic saline, 1 liter contains nearly 500 milliequivalents. So if I want to give 250, give roughly 500. This 500, I have to give it in 6 hours to achieve this increase of 6. So calculate it and it comes up to some 80 ml per hour. This is how I would give it. Is it too much? So that is how I would do it. Okay. Now, what is it? You can give the boluses. If they are continuously seizing, you have no other option. You have to keep giving the boluses. So next is, what about rapid correction? This is a problem that happens in chronic hyponatremia, where if you rapidly correct, and if the correction is more than 10 to 12 milliequivalents per liter in 24 hours, It can cause central pontine myelinolysis. It's characterized by dysarthria, quadriparesis, and loss of consciousness. There isn't any kind of antidote for this. Make sure that this does not happen actually. So medications that I mentioned, demiclocycline, sometimes we use it, not all the time. This is to block the ADH basically. In this SIADH kind of situations, you use these medications, demiclocycline as well as Vaptans. It's nephrotoxic, so people don't prefer to use it much. Next is Vaptans. There are selective as well as non-selective Vaptans. Conivaptan is a non-selective one, you give it IV. Tolvaptan is what we most commonly use. It's more selective. It acts on the vasopressin receptors in the kidney. Dose is about 15 mg starting, maximum of 60 mg you can give daily. It takes about 4 days for the effect to reflect. So in an acute situation, there is no point in giving it. Most of the time, this is given for patients who have SIADH and high volume. So overloaded patients in whom you want to correct the sodium, you can give this. This is not given for hypovolemic patients. They always ask us, cerebral salt wasting and SIADH. For the life of me, I cannot remember anything except the fact that CSW is a dehydrated patient and SIADH is a patient who is not dehydrated. Because there is a lot of antidiuretic hormone, there is not going to be any dehydration. Cerebral salt wasting on the other hand is because of neurological insults. Brain natriuretic peptides are released that will cause loss of water as well as sodium in the urine. So these are going to be dehydrated patients. So correct their hydration status, and if they are symptomatic, correct the sodium with hypertonic saline. SIADH is basically a patient with excessive antidiuretic hormone. So that is causing a dilutional kind of situation and a hyponatremia. In that, sodium restriction or fluid restriction is what you need. Remember, you have to read it and to understand. They are all hypoosmolar serum, hyperosmolar urine. Next is hypernatremia. So basically, hypernatremia is also a serious issue. Mild, moderate and severe is there. Severe is basically more than 170 milliequivalents per liter. Now what the clinical features, what happens here is the cells shrink, the neurons shrink, the water comes out of the neuron. So they start becoming restless, confused, lethargic, they'll start getting seizures, sometimes even comatose. It can affect the respiratory system. Because it affects the action potentials, they start to twitch and have all these ataxia, tremors. So these are symptoms they present with. Why has this patient actually ended up with such high sodium? Most of the time it's because of some fluid issue. So there has been an excessive loss of fluid or a decreased fluid intake. This is why they ended up with hypernatremia. Otherwise, you should see, have I actually given medications that is causing the person to have high sodium, like hypertonic saline or soda bicarb? This is something that everybody is given no doses. So that is one of the reasons. Next is feeds. TPN and hypertrophic feeds are there. Is that one of the reasons? Because when you exhausted all of the causes, sometimes it's actually the feed. So look at all these things. Just like in hyponatremia, look at the old sodium levels, figure out if there is chronicity or not. Chronicity you can gradually correct. So the tests that I would do, again same, blood glucose, serum creatinine, uric acid, all these things you can do. Serum osmolality and urine osmolality is what we really need. So how would I go about actually managing this patient? So the plasma sodium is more than 145. The reason it is low is because there is some fluid issue. It's either the patient has taken very little or the patient has lost a lot of it. So now I have to figure out what the problem is. So at the far end, you can see it's hypervolemic hypernatremia. I have given a lot of fluid which contains a lot of sodium. So the volume state is also high, sodium is also high. So it's either hypertonic saline or something like soda bicarb which I have given, which has caused the problem. Next is in the other end is hypovolemic hypernatremia. There's a lot of fluid loss which is in excess of the sodium loss. So the sodium loss is not as much, the fluid loss is more. I've lost it, the loss has been through the skin or the GI or the renal, wherever it has been lost. Next is euvolemic. So the volume state is okay, but the sodium levels are high. Why has this happened? This has happened probably because of diabetes insipidus. Diabetes insipidus basically means that the ADH is not there. That is the issue. Central DI or nephrogenic DI. It is not there or it is not acting. So in these kind of patients, their urine is going to be very dilute. It's going to be free water basically going out as urine. In the body also this free water is just going to remain and this sodium level will be reflected as very high. All the free water is lost, sodium is going to be high in the body. But they are euvolemic status. So if you check the urine osmolality, it's going to be very dilute. It's going to be less than 300 milliosmoles per kg. On the other hand, if it is more than 300, it probably means that there has been loss of free water which has caused the sodium to become high. But that loss of free water is not through the kidney. That loss is some extrarenal insensible loss, like it could be because of respiration through the mucous membrane or excessive sweating. So how will I go about managing this? So diabetes insipidus central as well as nephrogeny, you can read about it, differentiating all these things. Based on the volume status, I'm going to have to manage the sodium. So in a hypervolemic, which we've already mentioned, that is the soda bicarb and the hypertonic saline and all which I have given, which is causing the high sodium. Stop the extra source of sodium. Try to reduce the fluid status. You can give diuretics, but this is a little tricky. When you give the diuretics, they can get further dehydrated sometimes, and that can worsen the hypernatremia. So try to manage it by giving a little bit of 1/4 normal saline or so. That can help. So this is a bit difficult to manage. So avoid this situation at all costs with the medications. Next is hypovolemic. Simply replace the volume. Replace the volume, the sodium is going to come down. With normal saline, you can replace it. Lastly, your euvolemic hypernatremia, which is most of the time is DI basically. You will have to replace the fluid and you will have to give some definitive treatment for the DI. So how will you replace the fluid? With free water. The free water is all getting lost through the urine. Replace it with D5 or half NS and give medications. For the central DI is usually desmopressin, and for the nephrogenic DI it's thiazide. Thiazide which will help in sodium loss through the urine. So how am I going to calculate the water deficit? So I have mentioned I'm going to give 5% dextrose, half NS, all these things. How am I going to actually give it? I have to understand what amount of deficit of water is there in the body of the patient that is causing the sodium to be so high. So I'll apply this particular equation and figure it out. What you have to remember is the rate of correction in hypernatremia should be limited to 0.5 milliequivalents per hour. Correction should not be beyond this. So this is an example of how I would go about correcting this patient. Suppose a 60 kg adult woman has a sodium of 160. I want to bring it down to 140. So I have to find out her free water deficit. How I find it is I apply to this equation where I find her total body water, which is 50% of her weight. So that's 0.5 into 60. And you take whatever sodium the patient's got and what is my desired sodium. So 160 by 140. Apply all these things. You will get 4.2 liters is what I need to replace as free water. So free water is not half NS, it's 5% dextrose or it is free water. And how am I going to give this 4.2 liters? Basically, I want to decrease the sodium from 160 to 140. So that's a decrease of 20. To decrease this 20, I have to give 4.2 liters. The rate of correction for me is 0.5 milliequivalents per hour. So over how many hours should I give this so that the decrease is only 0.5? So that I have to calculate. So 4.2 liters of free water will probably be you have to give it over 40 hours actually, so that the decrease is only 0.5 every hour. Is that understood? So in the end, you have to add insensible losses also. Insensible losses also be there. While you sit and calculate all these things, don't forget about the insensible losses. Add 30 ml per hour of insensible loss also. So the 4.2 liters, I have to give it at 100 ml per hour for 40 hours to correct this. With each hour's 100, add 30 ml per hour of insensible loss also. So chronic hypernatremia is present for more than 48 hours. If you're going to correct this, make sure the targets are less than 10 milliequivalents in 24 hours, not more than that. Rapid correction will again cause cerebral edema as well as seizures. Then lastly, hypercalcemia. Hypercalcemia, basically the corrected calcium is more corrected for albumin is more than 10.3 milligram per deciliter, or the ionized is more than 5.2 milligram per deciliter. So if this is the case, then this hypercalcemia is a serious issue. So the common causes are, it could be related to parathyroid hormone, it could be because of malignancies and vitamin D. If it's related to parathyroid hormone, it's mostly an indolent cause, it's not going to present suddenly. You can manage it at a little bit more relaxed pace. But if it's because of malignancies, the management has to be a little bit quicker. So the tests that you will send out are parathyroid hormone, PTH related peptide, the vitamin D levels and the calcitriol levels. So how will we actually go about doing this? So first and foremost, you have to figure out, is it because of a hyperparathyroid state that is happening? So I will check the PTH levels. Are the PTH levels high? It is high. Why? It could be because of primary hyperparathyroidism. There's an adenoma or a tumor or some hyperplasia which is causing it. There is a congenital condition, it's a familial hypocalciuric hypercalcemia. Basically means that all of the calcium, it is not getting lost in the urine. It is just remaining in the body. It's because of a mutation, a genetic mutation. It remains in the body. So it's a familial condition. These are the situations in which the PTH levels will be high. So forget about that. I'm now realizing that the PTH levels are actually normal. It is not high. Then I have to check the vitamin D levels. Check the vitamin D levels. If the vitamin D is in excess, probably because of some vitamin D intoxication that this has happened. Or there is a condition where I have given excess of calcitriol. In patients who have granulomatous conditions like sarcoidosis and lymphomas also, the calcitriol levels can be high. So in all of these patients, calcium reabsorption is going to be very high. So the calcium levels will be very high in their body. Rule out all these things. Only then come to the diagnosis of malignancies and all that. So next you check the PTH related peptide. These are produced by malignancies usually of the genitourinary tract, the head and neck, small cell carcinomas of the lung. these malignancies are capable of producing a peptide that is sort of like the PTH, which is causing the hypercalcemia to happen. So if that level of the related peptide is high, I can assume it's probably some malignancy related. Another thing that you have to keep in mind is patients can have high calcium levels if they are prolonged immobilized also, because the osteoclasts start getting activated, there's bone resorption, their calcium levels are going to go up. So this is how I would understand how hypercalcemia has happened. Check the PTH levels first, check the vitamin D levels, then check the related peptide levels. So once I've checked all these things, I've understood what's happening. The manifestations that I'm expecting in this patient is basically there's something groans, moans, and something is there. Yeah, so it's all of this. So gastrointestinal nausea, vomiting, constipation, ileus, pancreatitis is basically secondary. High calcium levels can cause the QT to shorten, and sometimes they can have variable AV blocks as well. Renal, loss of urine through the kidney and nephrocalcinosis, neurologically depressed consciousness, and patients can sometimes even be comatose. So calcium levels, all these symptoms usually manifest when it's more than 12 milligram per deciliter. It is almost always present when it's more than 14. More than 16 is an absolute emergency. How will you go about managing all these things? Hydrate. Hydrate the patient, give 200 to 500 ml per hour of fluid, try and maintain a urine output of 100 to 150. Hypercalcemia itself is the dehydrated state, so you're trying to hydrate in that, and this hydration will also help in elimination of the calcium through the urine. So that is one thing. Forget about furosemide. Come to calcitonin. Calcitonin also you can give. It's 4 units per kg. You give it subcutaneously. Check the ionized calcium levels after 6 hours. If there is any increase, then you can give these doses every 12 hours. So for about 24 to 48 hours, you can give calcitonin. Problem with this thing is, its effect is only modest and it's got tachyphylaxis. So it's not like you can give it for a longer period of time. Next is steroids. Steroids like oral prednisone or hydrocortisone, these are usually given in hypercalcemia caused by myelomas as well as lymphomas. So the effect takes time, 4 days. Biphosphonates are also given, zoledronate, pamidronate. These drugs have serious side effects, nephrotoxicity. They also take time. So in an emergency situation, there's no point in giving the steroids and the biphosphonates. You can give the steroids. Biphosphonate is going to take time. So there's a monoclonal antibody, denosumab. The dose is 60 to 120 mg subcutaneously. You give injection. Onset is about 5 to 10 days. It's given in patients with sarcoidosis and malignancies. So what it does is it interacts with the rank ligand in the body and it affects the osteoclasts. So the resorption will not happen. This takes time. So in an emergency, what will you do? Patient is presenting with serious neurological symptoms, seizures, all of that. You've hydrated, you've given the calcitonin, and these are things that act quickly. You've given the steroids, you have to dialyze in the end. So dialyze, if they are diuretic resistant also, and if they are volume overloaded also, you can dialyze them. Now diuretics are a bit tricky. You can give, but most of the time in hypercalcemia, patient is already dehydrated. You give diuretics for calciuria to happen, you're going to sometimes worsen the situation. So look at the patient, each patient will differ and decide about diuretics. So hydrate, calcitonin, all of these are the hydrocortisone and the denosumab and all that, and biphosphonates, dialyze in the end. So yeah, thanks.
Thank you.
Thank you.
Any questions? Too exhausted? About 2 more sessions are remaining. We finish fast. Okay, so thank you, Naina. Let's open up the section, please.
Okay, thank you.
So again, this is nothing. This is going to be an exam review course. I'm not going to teach you anything about sepsis and septic shock. I expect that you are seeing these cases day in and day out. And when it comes to critical care, I would like to thank my teachers who taught me the basics of critical care. When it comes to critical care medicine, we all focus on the diagnosis of the management of life-threatening complications. We tried, but we all know that this requires constant monitoring. With the support of advanced medical technology, you need to back up your decisions by evidence, good practice evidence. And critical care is always a teamwork where communication remains the key. Okay, so this is the backbone why we are managing patients in the ICU day in and day out. So here comes, I will start a case now. It's going to be a case of sepsis with septic shock. And I want you to spell out the management, how you are going to manage the patient. I'll give you a scenario. It's going to be a continuous scenario. So I want you to tell out how we are going to manage the case. Mic ready ആണോ? Mic ready ആണോ? I think I don't need, പക്ഷേ ഇത് നീളമില്ല. Okay. Okay, so we'll just go ahead. So this is the case. I have a 62-year-old male who is hypertensive, diabetic, dyslipidemic. He presents to the ER with complaints of fever, malaise, and feeling of unwellness of 1 day duration. Please tell me when it's 30 minutes. He was apparently normal 24 hours prior. He was going to the market when he sustained a skid and fall He had some abrasions on the leg. So he immediately went to the local hospital. He was given dressings with normal saline and was advised injection TT. So he did both. He went home. Today morning he was feeling dizzy and giddy, with some giddiness. So he came to the ER. So when he came to the ER, his heart rate is 136 per minute. BP is 110/4/6 with a map of 67. Respiratory is 32. Saturation is 94% on room air. He is a bit febrile. E3, M6, V4. No focal deficits. Tachycardia, and because of tachycardia, no murmurs were appreciated. He had bilateral basal crepitations. Abdomen was soft with no hepatosplenomegaly. Because she joined us late, I'll start with you. This is the case. How will you manage the patient? പറഞ്ഞു തീർക്കണ്ടേ? പറഞ്ഞു.
Because he is having bilateral basal crepitations, I want to see the cardiac status.
Okay. So you
I will put the cannula and I will go blood. I am suspecting a sepsis, so I will go blood and they will see along that I will send the blood culture.
Okay, so if I go systematically, you said you will put in a cannula, you will send the blood, you will send the blood cultures, ABG, lactates, antibiotics, IV fluids, and you want to do a POCUS. Okay. I am a bit irritated because when a patient comes to you, we should go in a systematic manner always. Systematic manner starts with your ABCD, yes, definitely yes. Even before that, you should be also thinking about your vital examination. Okay. Now, when I say that this patient is heart rate of 136 per minute, now this mic is going to be passed off. I say this patient has a heart rate of 136, his BP is 110/46, respiratory rate 32, etc. Did you ask for an ECG? Did you want to better see whether the patient is in AFib or sinus rhythm? Probably yes, right? And before jumping into POCUS, so this is your POCUS, you wanted an ABG and this is your labs. So you have got your ABG, pH is 7.3, PCO2 65, PO2 42, lactate 3.8, bicarb of 18. I told you he was a diabetic patient. Would you have wanted to check for the ketones to know whether it's a DK? That also you have to spell out. Okay. So these are the labs that you have. You have some leukocytosis. You have some mild AKI and the sugars are high with a ketone of 4.8. Yes, you can see the echo there. Okay. So if you tell me, you told me the patient was in shock, so you did well in that. You didn't ask for an ECG. That is something that is I expect. So you secured a whiteboard access, very good. You didn't check for the sugars, knowing he is a diabetic patient. ABG, okay, but still you have to spill it out. Okay. And you told me about ABG, you told me about cultures, you told me about fluid resuscitation. At this point of time, if you didn't start vasopressin, you are fine. You started the antibiotics. I would also specify specifically, you told me that you suspected a Bayline's, but again, I would like to have a more detailed say that you look into all systems to see, because you're suspecting sepsis, because the patient is drowsy, I would like to assess for organ dysfunction. Okay. And this is a patient who has a surgical source of sepsis. So communication is the key, and you should call your colleague to come and see the patient, assess the patient for source control. Okay. And if you want to, for medical legal purpose, you can call the cardiologist for an AF management also. But again, surgery, source control was important at this point of time. Okay. Now, because you told me that you will check for echo, etc. You definitely did a good job. A DK you should have checked, and again if you said that I would be bothered about a compartment syndrome, I would look for compartment syndrome again, you would have a bonus point. But again, I would fail you because you didn't tell me that you examined the patient's limb. You didn't even bother to look at the patient's limb. Okay? Yeah, that was there for the history. Did you examine the limb? You should examine the limb. Okay? And because you didn't control the source at that point of time, I would be bothered about, and I may not pass you for the exam. And this patient has to go to the ICU. So again, you have to shift the patient from the ER to ICU, and so that a bed communication has to hand over. You should give a proper handover. You should arrange a bed, and probably will accompany the patient to the ICU. Okay. So now that's there. So the question comes to, what is sepsis? Yeah. So that's the sepsis 3 definition that has came out. We have a huge definition that is there. Now we know the sepsis is a life-threatening organ dysfunction due to a dysregulated host response. Okay. So is this patient in shock? If you see it, the heart rate was 136, MAP is more than 65. So is this patient in shock?
We need to know the lactate. We need to know the lactate also.
Lactate was for 3.8. Yeah. I've given you the whole details here. Is this patient in shock? You have a patient, MAP is 67, tachycardic, tachypneic, drowsy, easily arousable, confused.
Evidence of hypoperfusion plus lactate.
So this patient is in shock. Okay. So one thing is there is Q-SOFA. You can give, we know Q-SOFA. The newer guidelines doesn't say that you should not measure Q-SOFA. The guidelines suggest that don't rely on Q-SOFA as a sole marker. Okay. It is extremely sensitive but less specific. Okay. So you can use it because if it is there, something is wrong with the patient. Okay. Now, Naina was talking about shock index, the Algor's shock index, which is basically described in patients with burns initially. And there you have the heart rate divided by SBP. Okay. So as the index goes up, your mortality also goes up from 10% to almost 40% mortality. Okay. So basically just remember that your normal heart rate is 80 to 90. Your normal systolic BP is 100 to 120. So the moment your heart rate overcomes your SBP, something is wrong. Okay. Now, why is the timing of antibiotics important? Okay, speak.
Infection control.
No, I asked you specifically why the timing of antibiotics is important.
There is studies showing that every hour delay in antibiotic increases the mortality.
Do you want to modify that sentence? Is it every hour delay in antibiotic or is it something else? I wanted the word appropriate. Okay. So every hour delay in an appropriate antibiotic delay causes an increase in mortality. Okay. So this is a famous paper that we know. This is from Kumar et al. There's a significant increase in the mortality when you gave up just delay in the antibiotics. Appropriate antibiotics. Okay. So what is the recommendation of antibiotics in the new survival sepsis guidelines?
Broad spectrum.
Okay. For all. Now what is the new survival sepsis campaign guidelines talk about antibiotics in shock or a patient coming to shock? So basically it classifies the timing of antibiotics is now based upon whether shock is present or not. The patient has shock, you have to administer antibiotics immediately. The patient doesn't have shock, probably you have some more time, but 3 hours is the maximum time before which you should decide whether the patient should receive antibiotics. Okay, first minute. Now, fluid resuscitation. She wanted to start. She wanted to have a large IV cannula. She wanted to start fluids. Okay. Now, so how much fluids do you usually give?
30 ml per.
So from where did this value come? So probably that the concept of sepsis resuscitation, there was a paradigm shift in the management from this trial, EGDT trial. This was done by this man in Emmanuel Rivers et al. And what he did was, in his subset of patients in the university that he was working, he started with fluid resuscitation. Once the fluids were replete, we measured that with CVP. Once the fluid was replete, he then optimized the BP. Then he optimized the oxygenation targets. Okay, he optimized oxygen delivery. and he found a significant reduction in the mortality of almost half 50% mortality. So from 44% your mortality dropped to 30%, 15% mortality reduction. Okay. So this was probably the first trial that showed a mortality benefit in critical care. What are the other trials that have shown a mortality benefit in critical care? So Stewart has tried, prone ventilation has shown a mortality benefit. Any other trial? Anana steroids basic, these are this is a negative trial. Anana basically statistics gimmicks positive. Your low trial volume strategy, the ARMA trial in 2000. Okay, so that is probably the first trial that showed a huge mortality benefit. Okay, and if you see the impact of this reverse trial, you see the number of citations done by your ARMA trial and reverse trial. Okay, it was everywhere people were taking up because it was a significant reduction in the mortality benefit. But again, people were a bit skeptical by the methods he went ahead, because whether CVP really predicts fluid responsiveness is a doubt, and whether we should be using the catheter. But he measured SCVO2 continuously. So basically he inserted a central line, and that central line tip was connected to the monitor, and the central line used to continuously give the value of SCVO2. It's called the pre-sub catheter. Some allegations that he had some funding, he received some funding for that pre-sub catheter, we don't know. Okay, but anyway, this received a huge attention in the field of critical care. Okay, now, so this came the guide. So from this trial came the guidelines that probably you should be targeting CVP, MAP, and urine output for all patients with sepsis and septic shock. This was in 2012, and by that time we came to know that probably CVP is not useful. 50% of your patients will be fluid responsive, 50 will not, and again MAP again differs from person to person. So probably they changed it that you start with 30 ml per kg. You don't need to monitor the CVP. You start with 30 ml per kg. So that became the guidelines. Okay. And now the 2021 guidelines suggest that you suggest at least 30 ml per kg should be given in the first hour or 20 minutes. In the first 3 hours. Okay, you have time for 3 hours. It's not that you should be rushing on all the fluids. You have time to give it within 3 hours. Okay, pass the mic. Again, as I told you, there's no strong basis for this 30 ml. There were 3 other large trials that looked into the EGDT that reversed it. Reversed did the EGDT in 2001. After that, there were 3 large trials that also looked in the same procedure. So they are the ARISE, PROCESS, and PROMISE. And they found the ARISE, PROCESS, and PROMISE found no benefit in the EGDT per se. Okay, but one thing was striking was that almost all groups received approximately 30 ml per kg. Okay, so now they assume that okay, now this has become almost a standard norm, and any patient coming to us will require at least this much fluids. So that's why the surviving sepsis guidelines now suggest 30 ml per kg for resuscitation to be given within 3 hours. Now, does giving fluids always help? So this was why do we give fluids? So this is a curve that you have seen at least multiple times, right? So this is a curve that has told you that if you increase the preload, if you increase the stretch, then probably the stroke volume will increase. At the same time, if your heart is on the flat part of the Frank-Starling curve, you are not going to increase your stroke volume. Okay, how does this apply to? So who are you going to give fluids? You are going to give fluids in patients who have hemodynamic instability, who have signs of hyperperfusion like hyperlactatemia and hypotension. Okay, these are the patients: hypertension, hyperlactatemia, and hemodynamic instability. Okay, these are the patients where you are going to start giving fluids. Why? So why do we give fluids? Why do we give fluids? To increase the oxygen delivery. Okay. Now, if you want to give fluids to increase the oxygen delivery, I just want to know whether you got the concept correct. Why do you give fluids? Okay. Why do you give fluids? You give fluids to increase the oxygen delivery. Okay. How does fluids increase the oxygen delivery? By increasing the cardiac output. So if it's fluid responsive, by increasing the cardiac output, it will cause increase in fluid oxygen delivery. Okay, but at any point of time, this is the secondary analysis from the Andromeda shock trial, that a patient who comes to your ICU today, day 0, 70% of them, 82% of them will be fluid responsive. So 70% will be fluid responsive, and 30% will be fluid and non-responsive. So the 1/3 of your patients, if you are seeing 10 patients, 3 of them will not be fluid responsive, even though they are hypotensive, even though they have hyperlactatemia in the ICU. And the fluid responsive patients rapidly become fluid unresponsive in the ICU, while the fluid unresponsive patients remain unresponsive throughout the ICU stay. Okay, so even if your patient was fluid responsive to start with, he may not be fluid responsive afterwards. So you have to keep on checking fluid responsiveness in the ICU, right? This is because this is the formula for oxygen carrying capacity, and if you give fluids and if you increase the cardiac output, then the oxygen delivery increases. If the cardiac output doesn't increase, what is going to happen is you are going to have a hemodilution, and that hemodilution is going to cause a decrease in your oxygen delivery, so it can cause more damage, right? Okay. Now, what are the tests for fluid responses that you have? So basically, you have static parameters and dynamic parameters. What are the static parameters that you know? CVP, IVC, etc. What about the dynamic parameters? Stroke volume variation more than 13%, 10 to 13%. PPV, 10 to 13%. Okay. PLR, okay. You can use an end expiratory occlusion test. You can use a tidal volume challenge test, or you can use a PLR, or you can use apical 5-chamber to note the VT, aortic root VTA. Okay. So what is the surviving sepsis campaign guidelines suggest? Do they suggest static or dynamic? They suggest dynamic parameters over static parameters. Okay. Give the mic behind. So sepsis is a state of relative hypovolemia because there is a vasodilatation, etc. It's a state of relative hypovolemia. So whether should we give crystalloids saline solution versus balanced solutions? What's the debate right now happening? Is there any benefit with balanced? What does the guideline say? Crystalloids, yes. Saline or balanced solution? So in the 2021 update, they suggested probably you may shift towards balanced solution based upon the smart trial that came up in between. Okay, but again, I'm not a very huge fan of balanced solution. You can say normal saline was not that harmful, and there are certain indications where you should be using normal saline. We'll come to it. Now, if he needs blood, unless he is bleeding, his target is 7 mg per deciliter, and if your patient requires large amounts of fluid, you are going to give albumin. So this is the recommendations from Subsurviving SSC 2021, and there is clear-cut guidelines that you are not going to use starches, gelatin, or any hypertonic fluids, right? Okay. Now, hyperchloremia seems to cause some amount of renal vasoconstriction, and it might be harmful. Okay, but again, if you have a neurotrauma patient, there is no doubt the only fluid that you are going to give is saline. Okay, there is no question of giving balanced solutions in those patients. If a patient has metabolic alkalosis, you are going to give saline. Okay, so these are the indications where you are still going to use saline. But again, as I told you, there is no strong signal of benefit for balanced solutions. But the guidelines do recommend that. We suggest using balanced solution crystalloids instead of normal saline for recommendation. That is the 2021 guidelines. Okay. Now, can you use albumin? You can use albumin. Okay. So, do you know anyone know about the story behind albumin? In 1998, there was a Cochrane meta-analysis of albumin versus fluids that suggested that albumin actually killed patients. The people were panicked, people were worried, and the sales of albumin also plummeted down. Now, in the safe investigators in Australia, where they use extensively albumin extensively, they did a study which is called a SAFE study. Okay, and they suggested that in all these groups, trauma, severe sepsis, and ARDS, probably albumin was as safe as saline. And we had a notion that albumin being a colloid, you will require less volume than a crystalloid. Colloid is supposed to remain in the intravascular space more than a crystalloid. But again, they debunked it, and they said that if you are using 1200 ml of normal saline, then you will have to use 1000 ml of albumin. 200 ml, 200 മുതൽ 600 ml വ്യത്യാസം മാത്രമേ നോർമൽ saline കൊണ്ട് ലാഭിക്കാൻ പറ്റുന്നുള്ളൂ. ബാക്കിയെല്ലാം is almost same. Okay, so compared to the cost, probably I might still continue using normal saline in my subset of patients, but again, this is what the guidelines say. Now, in a subset of patients who had traumatic brain injury, they found that use of albumin increased the mortality, and that increase in mortality was persistent even after almost 2 years. Okay, so traumatic brain injury, albumin is out, or at least hypertonic albumin is out, 5% albumin is out. Okay, now there was a subset of patients in septic shock where they thought that it might be beneficial. So again, the Albios trial was used. To make a big story short, the Albios trial also didn't show any benefit, and the mortality was almost same. Now people do suggest that there was a slight benefit in the subset of septic shock, but again, that is just hypothesis generating. So the surviving sepsis guidelines suggest that for patients with sepsis and septic shock who receive large volume of crystalloids, they suggest albumin. Okay, and they recommend against starch and gelatin. It's clear for that. So if you look into the history of fluids that have been going, the patients have become less and less positive. From almost 10 liters per day at the end of the ICU stay, they have come down to just 1200 ml positive by the end of the Clovers trial. This is how we have moved from a liberal fluid strategy to a restrictive fluid strategy over the years. Okay. Now, where's the mic? So your patient has reached ICU from ER. He has already received injection meropenem 2 gram stat and 500 ml of normal saline. He has reached the ICU. He is drowsy, disoriented, E3, V4, M6. Although they didn't take although the doctor didn't order an ECG, the nurse by default took an ECG which shows an atrial fibrillation, and BP is 96/48, respiratory rate is 28 per minute. He is saturated 92% with 4-liter oxygen by a simple face mask. How will you manage the patient?
Sir, first of all, he has only, if you see the fluid resuscitation, he has only received 500 ml of fluid. So, since he's hypotensive, I'll continue on fluid resuscitation. At the same time, think of starting vasopressors along with the fluid resuscitation.
So what does the surviving sepsis guidelines suggest? Co-administration. There is no point to, there is no need to think of it. You are going to co-administer fluids with this thing. Okay, right. Okay, then we're done. This patient reaches the ICU, you are on duty. Are you done? I want you to feel the എല്ലാവരും സംസാരിച്ച് പഠിക്കണം അതിനു വേണ്ടിയാണ്. Okay.
I would think of placing an arterial line to look for
Okay.
For blood pressure measurement, and then look for fluid responsiveness also.
Okay. Okay. So, did you repeat the ABG? That has gone up slightly a bit, but that's something that you would do. Usually, that is something that you will do. You have to speak it out. Okay. So, I would give points if you told me that you will assess the medical records and reconfirm the details. Okay. Again, the ER doctor has not examined the limb, which you also failed to do. Okay. You will have to examine the limb, and probably you will have to mark the border of the cellulitis. Now, cellulitis Mario, you have to mark the borders also. Okay. and you will have to say that you are going to reassess the patient. You put an arterial line, but probably a capillary refill time or an ABG or doing a repeat echo was very good enough before putting an arterial line. And you told me that you very well told me that you are going to do fluid responsiveness, but you didn't bother about the heart rate when I told you you had atrial fibrillation. Probably that's something that again you will tackle at this point of time. You would recheck the sugars because he came in decay, and you would place a Foley's catheter which was not put in the ER, and you will take a cardiac review. You may think now the patient is hypoxic, saturation 92% with already forwarded simple face mask. So you may think that probably it's time to move on to step up the oxygenation, and whether he requires intubation or HFNC or trial of NIV, and whether the antibiotics or source control is adequate. So again, you will have to call in your surgical counterpart to see the limb and to assess for source control. Okay, I would have given you bonus points if you put this arterial line in situ. This being in a cellulitis case, most common organism is going to be staph or strep. So again, if you told me that meropen is not adequate, I'm going to give clindamycin also. It will be in a bonus point. IVIG is a bit dubious. There is not much of recommendation for IVIG, but the Europeans are fond of it. So if you are writing an EDIC exam, then they will want IVIG from you. Otherwise, I would not have put IVIG in this. And probably if you told me that you are going to intubate, the marks would have given for intubation bundle or RSI. I would not accept it if you didn't examine the patient, if you didn't counsel the relatives, if you didn't call for a surgical consultation, and if noradrenal was not started, I would not accept that, because we'll come to that. So what is the role of lactate in resuscitation? Why does everyone want an ABG to look at the lactate, why do you want to look at the lactates?
End organ perfusion.
Okay.
It's a marker.
It's a marker of end organ perfusion. Okay, agreed. Then, okay, Maria, how do you classify lactic acidosis?
Type A and type B.
Type A and type B. So that's the Wood and Cohen's classification of lactic acidosis, where you classify it into hypoxic and non-hypoxic, and non-hypoxic again classified into B1, B2, B3. Okay. Now, why do you have hyperlactatemia in sepsis?
There is hypoperfusion and anaerobic metabolism. The end product of anaerobic metabolism is lactate. And,
so probably it is not just anaerobic metabolism that is happening. Your
There's
body is
decreased
in an
clearance.
adrenergic drive. So when you have an increased adrenergic drive, you tend to shift more glycolysis into the Krebs cycle. The Krebs cycle cannot take that much of things. So it will push into the lactate cycle. Okay. So yes, and some amount of anaerobic metabolism might be there, but more than that, your adrenergic drive will be there to produce more and more lactates, and your liver will be hyperperfused. So the lactate clearance also will be on the lower side. So a combination of increased production and reduced clearance is responsible for hyperlactatemia. Okay. Now I agree with all of you that serum lactate is a predictor of mortality, and even if the patient is in shock or without shock, so even if a patient doesn't have shock or has shock, whether you have a hyperlactatemia or not, your mortality is higher. If you have a low lactates, your mortality is less. If you have a high lactate, the mortality goes up. Okay. And this was the trial by Jones et al. In 2010, where he wanted to change the focus from SCVO2 to lactate, and he wanted to target a reduction of lactate by 20% per 2 hours in the initial 8 hours. Okay, and he found that probably the patients who had a reduction in lactates had a better mortality. Okay, so that's again why we are looking into lactates. Now, the caveat to that study was whether the patient reduced lactate or not doesn't really depend upon us, because the production nor the clearance is not really dependent upon us. If the patient is responding to our treatment, he will reduce the lactate. So probably a lactate clearance is just going to tell us whether the patient is responding to your treatment or not. Okay, right. Now, why I am saying so is, this was a trial that into 1996, I think, 1995 or 1995 by Stackpool, where they try to reduce the lactate by giving a substance called dichloroacetate. Okay, and you can see that the lactate levels statistically came down, significantly came down. Okay, in the group that received dichloroacetate, the lactate significantly came down, but the mortality went up. Okay, so probably lactate is not something that you need to be bothered about, so that you have to aggressively reduce it. It's going to be a marker to tell you whether the patient is responding to your fluids. And some people do think that lactate might be beneficial to the heart also. Okay, heart and brain. So the surviving sepsis guidelines recommends that for patients coming with sepsis and septic shock, you should be measuring the lactate, and you have to remeasure that within 2 to 4 hours to guide your normalization. Okay, and again, in patients with hyperlactatemia, you should try to IV fluids as early as possible. Okay, right. Have you heard about this Andromeda shock trial? Can you tell me what it is? So they checked whether lactate clearance or capillary refill time is better. Okay, and they found that probably there was a non-significant mortality benefit in the patients who were resuscitated by the capillary refill time. Okay. Now, if you go into the post-hoc analysis of these patients, I had a hyperlactatemia and a normal capillary refill time, and those patients, if after my second point, if I had a normal lactate, my mortality was 35%. Okay, I had a high lactate. They resuscitated me. My CR capillary refill time became normal. Okay, then if I had a normal lactate, it was fine. But if my lactate was high at that point of time and you continue to resuscitate me, the mortality was 44% instead of 35%. So probably overdoing the resuscitation at this point of time might be more harmful. Okay, that is because lactate may take some time to clear. Lactate may not, as I told you earlier, lactate production might be because of many other reasons. So you really need not to aggressively target. Targeting a marker of capillary refill time may be better. Okay. Yeah. So they suggest measuring blood lactate, which is a weak, low quality evidence, and they suggest guiding resuscitation to decrease serum lactate over not using serum lactate. You are with me? Okay. So what is an adequate initial MAP target?
65 millimeters of mercury.
From where did they get that? Okay. So they got it from in an SICU where sepsis was recognized. They found that the mortality in 1994, 2014, the mortality seriously went up for every hour of delay in the MAP less than 65. So that's why they targeted the target came of MAP more than 65. Anthony, mic. So they found that every delay of MAP or persistence of hypertension of every more less than 65 increase the mortality by 5%. Okay. Now, whether MAP versus say 65 to 70 is adequate, or should you go for a higher MAP? What are the findings of this? What is this trial? This was a sepsis spam trial that suggested that there is not much of benefit of increasing the MAP from 75 to 85. Okay. What is the subgroups that showed a benefit? In patients who are chronic hypertensive patients, the number of the renal adverse effects was less. Okay, the recommended dialysis was less at a risk of increased arrhythmia. Okay, is there any other trial that looked into it? Yeah, so there's another trial that looked into it, the 65 trial. The 65 trial looked whether 60 to 65 is safe, and they found that in elderly people, paradoxically, in the chronic hypertensive patients, a lower MAP was safe. Okay, Sepspam told that a higher MAP was safe in chronic hypertensive patients. They found that there was no difference with the lower MAP, and even in the chronic hypertensive patients, there is no difference in with no harm with your lower MAP. Okay, so probably somewhere around 60 to 65 is safe, and then you will have to individualize your target. Okay. Now, why is intubation bundle? Why is intubation in the ICU so difficult or risky or something? Why do you want to have an intubation bundle? You are an anesthetist, so you have intubated many people in the OT. Why is intubation different in the OT and ICU?
Most of the time, ICU intubation will be in like emergency scenario, not like elective.
Okay, number one.
Second one, sepsis. We have to intubate according to the clinical condition of the patient, whether we need to go ahead with the RSI or take care of the ICT. So the drugs may vary in the ICU, not like.
It is always rapid sequence intubation. Okay. Ketamine, scolinum, ICP കൂട്ടുന്നുള്ള പഴയ ഒരു ധാരണ നമ്മളിപ്പോൾ അതിൽ നിന്ന് പതുക്കെ മാറുക. വലിയൊരു ഇമ്പ്രൂവ്മെന്റ് ഇല്ല, വലിയൊരു ഇൻക്രീസ് ഇല്ലെന്ന് നമ്മൾ പറയണേ. So I wanted the term called physiologically difficult airway in the ICU. You may have an anatomical difficult airway, yes, but I wanted the term from you that it is a physiologically difficult airway because your patient might not be at the FRC might not be at the optimal FRC. You may not be able to attain that level, and again because these patients are hypotensive already, your anesthetic agents or induction agents can just crash them. Okay, then again the OT is a place where you have multiple armamentarium around you, the experienced people around you, where ICU probably you will be alone and it will not be the ideal intubation condition also. So again, so this is why intubation bundle is important, and the intubation and before that again people now we are changing that you should be pre-oxygenating the patient with either HFNC or NIV before intubation. Okay. So I think you all know about an intubation bundle. Yeah, it's not new, right? So there is something called an intubation bundle because that can help to avoid unwanted complications. Okay, Matthew. The patient was intubated by Amrita in view of hemodynamic instability. His heart rate is still, she didn't give amiodarone, so heart rate is still AF with FER, heart rate of 148, saturating 98% with FiO2 of 60. Now, because her senior scolded her, she has called the surgical resident. They came and they did a debridement at the bedside, and a Foley was also put. NORAD has gone up now to 0.4 mics per kg per minute, and the urine output is 500 ml till now. The counts are there: 32,000 WBCs, urea 106, creatinine 4.2, sodium 142, potassium 5.6, GRBS 225, ketones of 1.5. I assume that the BP is at least map of 65 is maintained with this NORAD of 0.4. How will you manage the patient?
Okay, so first the heart rate is still, she has not yet controlled the AF, no, so what's the BP?
I assume it is 65, map 65, or 70.
So just I'll consider dose to vasopressin since it has gone up to more than 0.25 microgram per kg per minute. And if I have an, I think by this time that line might be in situ.
Yes.
So I'll just try with one shot of cotton 150 mg. Amiodarone of 150 mg. So and since we have not yet started stress dose steroids, we will consider giving hydrocot. I'll just modify the drug chart, giving hydrocot and escalating vasopressor requirements. Then regarding the lung ventilation part, 98% will be more than 60, but still it will be more mild to moderate, less than 150. The patient will be in sepsis. Still, the patient will be on NIV now, mostly.
Intubated.
Oh, intubated. Okay. Okay. Sure. And the other issue is from the beginning, the patient has only passed urine output of 500 ml. As we can still go ahead and see that whether the fluids has gone up like 30 ml per kg, the initial fluid.
So I would be happy if you had started a Riles tube. You said that you would check for Riles tube. You would start sedation and analgesia for a patient who has undergone debridement and intubated. You would repeat the ABG again because it's day 1. You would reassess the need of reassess the heart condition before adding a vasopressin, and you may think whether the patient requires fluids or not. You told me that you will consider hydrocortisone and vasopressin to maintain a MAP more than 65. You told me you will monitor the intake output very good. None of you are still now picking the point that patient's sugars have to be monitored. Okay, the patient came in DK and the sugars have to be monitored. Okay, And because now you are starting to be tending to be oliguric, it is time to call in your nephrology friends for reference. And you may consider AF, you may consider AF control, bicarbonate, and you may consider AF control. Unfortunately, you didn't ask for an X-ray post intubation, which is, you should ask. That's not my fault. What does the X-ray show?
It's endobronchial intubation, it's a left lung collapse.
Okay, so you should ideally pull out the tube and maintain the ventilation. Okay, so you should ask for a repeat chest X-ray after intubation and rise tube placement. And if hourly you would not put it, so I told you 100 ml was there, but was it an initial urine that is clogging the bladder, and what's the output now is what makes importance. And again, if you told me that you would check for fluid responsiveness, you check for the lines, the central line was inserted, whether there's the knowledge is going or not. And again, if you wanted, because the patient has to receive massive fluids, etc., you are bothered about intravenous hypertension or excess, okay, you get additional bonus points. But I would fail you if you tell me that you would make sure, if you didn't send the debridement tissue for cultures, if you have not contacted with cardiology, if you didn't reassess the patient's cardiac status, and if you have not checked out for the chest X-ray after intubation, again, I think that will mark you grossly against you. Okay. So, what is the second choice of second vasopressor choice?
Vasopressin.
Vasopressin. Okay. So there have been there's a huge debate earlier. In 2004, it was noradrenaline equals dopamine, and then in 2010, you had a soft trial that showed that probably noradrenaline fares better than dopamine, especially in the cardiac subset of patients. And then vasopressin came into the second line. So this is a soft trial that was published in 2010 that showed that almost in all groups it is equal, but in a patient subset of cardiogenic shock, the dopamine produced increased mortality because of increased arrhythmia. So there have been numerous trials that looked into it, and again, the surviving sepsis guidelines suggest that vasopressin we start with norepinephrine, and second thing is when we can't retain the MAP, you will think of adding vasopressin. And then if you still think of patient is not being able to attain the MAP, you will think of adding epinephrine. Now they clearly say that it's not that dopamine is really bad for each and every patient. If you don't have in these drugs, you can still use dopamine. Okay, but again, it's better that you start with noradrenaline. And they recommend against terlipressin. So which ionotrope? I think I already covered it. That you can either use norepinephrine with dobutamine, or you can use epinephrine. You can see that the square boxes are that of epinephrine, and other is the triangle box is noradrenaline plus dobutamine, and almost always the MAP, the cardiac index, heart rate, lactate clearance, PCO2 gap, and diuresis, almost all were same at the end of the 24 hours when you use either of these. So it doesn't matter whether you are using epinephrine, adrenaline, or you are using a combination of noradrenaline with dobutamine. Okay, and even the lactates, I think lactates even see the lactates at the end of 1 hour. We are all scared to use adrenaline because the lactates might go up. At the end of 24 hours, the lactates are almost the same in this as per this trial. Now, Thomas, is there a role of bicarbonate in metabolic acidosis?
In replacement,
This patient, bicarbonate carry on
if there is severe metabolic acidosis and a threat of cardiovascular collapse.
pH 7.13 or 7.2. Okay, first okay, so probably there's a trial that looked into it. It's the BICAR ICU trial. They looked at patients with pH less than 7.2, PCO2 less than 45, bicarb less than 20, and patients who had SOFA more than 4 and lactate more than 2. And they found that this is a mixed group with both medical and surgical patients with sepsis, shock, hemorrhagic shock, cardiac arrest, and patients who were really sick. 83 patients were intubated and 80% patients were on vasopressors, and they had a median bicarb levels of 13, and they found that in patients with Akin score 2 and 3, administration of 4.2%, it's not 8.4%, administration of 4.2% of soda bicarb may probably have a reduction in your RRT days. Okay, so that is the Akin trial. Now, what's the role of steroids?
We can give stress drugs.
So till 2016, the guidelines was recommended against the stress dose steroids. What happened after that? Do you know any trials that came after that? There are two large trials that came into it. It's the adrenal trial and the APROCUS trial. The two and CRRT in sepsis.
Heme absorption doesn't have much role, sir, but see, RRT can be given for the if the patient is in acute shock and oliguria is there, acidosis, persistent acidosis which cannot be controlled.
CRRT or SLED?
CRRT will be a better choice in hemodynamically unstable patient who is requiring double support.
As per the guidelines?
CRRT.
No benefit. Okay. And early SLED versus late SLED?
Early SLED.
No benefit. Okay. So probably there's no role for heme absorption in sepsis, and there's no role for early versus late in the ICU. You have absolute indications where you can start, where the patient is either having volume overload refractory to medicines, hyperkalemia refractory to medicines, severe acidosis, or manifestations of uremia and uremic encephalopathy, seizures, uremic pericarditis. Okay. Yeah. Now the patient is stabilizing. He's on clindamycin, meropenem. The cultures grew strep pneumonia. He's on RRT for oliguria and acidosis. Initially, he was started on CRRT because he was hemodynamically unstable. Now we are shifting on to SLED because of the cost issues. Oxygenation has improved once we pulled out the tube. He's on F5 to 30. Chest exercise is better. Sugars are controlled and wound is healing. How will you manage this patient?
I can de-escalate the antibiotic at this time.
Okay. Very good.
Maintenance of the
okay. So the points that I want to say is something that you do every day, day in and day out of the patients. You will assess the intake output of these patients. You will assess for adequate nutrition. You will assess the bowel output, bowel movements. Again, you told that you will de-escalate the antibiotics. By day 7, you can stop the clindamycin and de-escalate the antibiotics meropenem also. Now this is the time where the effort has come down, so you can think about daily sedation, paralysis whole day, assessing for DVT, and again maintaining adequate analgesia and analgesia break. At this point, when I would have given you bonus points because the effort is only 30, so you could have assessed for extubation at this point of time. You would have assessed for delirium and pain. If you have communication with the patients, if you have mentioned that, if you mentioned about ABCD and bundle of weaning or the DVT prophylaxis. But again, I would not be that happy if you didn't mention about the nutrition, or if you didn't mention about the antibiotics dosed according to your renal clearance. So when will you start feeding in the ICU? Okay, I go a bit fast. So if your NORAD requirement is less than 0.3 mics per kg per minute, probably you can start feeding these patients. So I don't think fast track BID is there. Now I'll quickly end again with crossing up. The patient appears dyspneic. Saturation is 98. Respiratory rate is 32. He is having fever. There is an increase in total count and decrease in platelet count. He is having good urine output. RFT is elevated, but the trend is reducing. The creatinine is gradually coming down to 4.1. He has bilateral repetitions. How will you manage this patient?
Possibility of VAP.
Very good.
I have to consider. Then I have to take an X-ray and I have to do the focus and assess the lung parameters and cardiac parameters.
Very good.
Then fever is still present, so I will send for another 2 sets of culture.
Okay.
A platelet count is decreasing. Maybe he might be going for DIC, like that, sepsis DIC.
Okay. Okay. So again, we told me that you will reassess the patient. You will check for secretions. You will check the ventilator settings, and if required, he will take a patient on control mode. You will do a bedside focus. You will ask for an ABG. Repeat the cultures. Assess the cumulative balance, which is extremely important because the patient is oliguric and received fluid resuscitation. You will consider for assessing DVT as a cause of pulmonary embolism and breathing difficulty, and you will consider VAP, and you may think of escalating the antibiotics. You will have a bonus points if you thought that now the dialysis is not required, so I'll remove the SP catheter, and you send appropriate cultures and fever is managed. At the same time, if the patient who is increasing breathless, you may have to assess about the DVT, tube patency and paralysis of the patients. You can have increased secretions and tube block also, so you have to assess the patency of the tube. So again, that she has diagnosed it as VAP. FID requirements are increasing. A PF ratio is 106. X-ray shows bilateral consolidations. Blood cultures showed Klebsiella ESBL. BAL showed Candida and Klebsiella XDR. Urine showed Candida. How will you manage this patient?
Since the patient is having a Klebsiella XDR in the ball and might be probably a VAP, we have to escalate the antibiotic from meropenem to the mostly we have to see the panel and we have to assess what antibiotic you have to assess.
This is the ESBL report. This is the
ESBL
XDR report.
meropenem
This is the
is
XDR
okay.
report.
So it is G and colistin. You can add to meropenem. You can add polymyxin B.
Nero is resistant.
You can add colistin sensitive. So polymyxin B can be added. Can go for the classification. Any resistant strains are there.
Okay.
So we can go in for the XDR means you can go for the services that histrionium avibactam combination and synergy you can test.
Okay. So again, I would be happy if you rule out cardiogenic pulmonary edema, starting antibiotics for MDR, XDR, Klebsiella. You would always want, I told you bacteremia was there, so you would have to check for differential time to positivity and remove the lines if it was positive. Patient PF ratio is 106. You have to paralyze the patient and start patient on ARDS-NET protocol. And you may also want to think about proning this patient at this point of time. If you want to, because if you are so confused about the antibiotics, you can call for an ID consultation. And urine panel did not require management. And probably again communication with the bystanders takes an important role, and you have to communicate to the bystanders regarding a prolonged stay in the ICU. I will be happy because you mentioned the synergy or Carbar mentioned. Again, you should be thinking about the patient has to be given contact precautions and ECMO consideration if the prone ventilation fails. I would not be happy if you didn't tell me ARSTAT ventilation or prone ventilation at this point of time. And again, if you had used tigecycline for the bacteremia, I would have been extremely pissed off. How do you approach Candida in bile and urine? Candida in the bile and urine, I'm going a bit fast. Candida in the bile and urine are not treated. And in the patient with sepsis and septic shock with high risk of MDR organisms, we start with 2 gram negatives, and then once we have the cultures, we de-escalate to single anti-cultures. If you have a risk factor for MRSA, which is presence of MRSA in the last 12 months, it's hemodialysis, presence of CBC or immunosuppressant, drug addiction or ARDS, or if you have a history of ESB or pseudomonas. But whatever be this risk criteria, I would recommend you to say that you would start the empirical antibiotics based upon your hospital antibiogram, okay? Because this might not be applicable to your scenario. So you will change the antibiotics, empirical antibiotics based upon your hospital antibiogram, and you will deliver the antibiotics as per the PKPD. Now, you please go through that. So PKPD is something that we try to optimize by giving a prolonged continuous infusion for beta-lactam antibiotics. So basically, what we want to avoid these peaks which are associated with more drug toxicity, and we want to maintain a steady state. But if you look into the data from the Blink trial per se, there was not much of difference in the continuous infusion versus Ebola infusion. And again, multiple meta-analyses also have not shown much of a difference, but probably it might help if you have a infection in the sanctuary sites, or if again we don't have much data regarding whether it helps in our scenario where our incidence of MDR might be high. So again, I think I will stop with that. Yeah, thank you. Any questions? I'll be happy to take.